Hello to everybody and welcome to this new clinical webinar on the NIRVANA system. Today I'm very glad to stay with the Dr. Luciano Bissolotti, and he is going to explain us how they are enhancing the multidisciplinary rehabilitation of neurological disorders thanks to the NIRVANA paradigm. In particular, the Dr. Bissolotti is a specialist in the physical medicine and rehabilitation, and he is currently head of the rehabilitation services here at the Rehabilitation Hospital Domus Salutis in Brescia, and head of the neuromuscular and adapted physical activity laboratory, always here in the Domus Salutis. So thank you very much to this presentation and to this great opportunity to learn your experience. So I give to you the possibility to explain your content.
Okay.
Thanks.
Thank you, Federica, for introducing me to the colleagues, and hello to everyone. I want to share with you today our experience in the use of this virtual reality system, the NIRVANA One. This is a very interesting system because the BTS Bioengineering here in Italy provided this device thanks to their experience in the field of movement analysis, and in this way they had the ability to provide for the clinicians a lot of information about the type of exercise and clinical activities we are delivering with our patients. This is very important, just in the aim not only to deliver the treatment, but even to assess the results derived by the treatment as well at the same time. And this type of technology can be considered a very immersive one because of the different patients and the clinicians can live the experience of the rehabilitation session while having the possibility to do exercise on the wall or on the floor of the immersive room. And we are able nowadays to introduce in this type of treatment adult patients and young patients. But today we're going to talk about the results that we are obtaining from our adult patients. The clinician that is managing the rehabilitation session is able to decide which type of exercise the patient has to do, or the series of exercises that the patient has to do during the rehabilitation session, thanks to a specific software that can be used from the laptop or from the smartphone or from the tablet. And at the same time, just immediately after the end of the session, the clinician is able to get immediately the results derived by the rehabilitation program. As you can see here in this video, you can see that the physiotherapy of the clinician actually is delivering this type of exercise with the patient, but immediately during the treatment, the clinician can decide to change the setup of the exercise, and at the same time, the clinician can provide verbal stimuli to change the type and the paradigm of the exercise. On the second time, the patient can even do exercise in a standing position in the aim to follow a certain type of exercise with different targets, and according to their own ability, the patients can be live by themselves in exercises, or eventually they can be assisted straightly by the physiotherapist during the treatment session. As you can see, you can change all the different exercises in a very, very quick way. The very interesting fact is that the clinician can work at the same time under a multidimensional point of view to a cognitive task, a motor task involving the upper limb recruitment, the balance, the trunk, and the lower limbs. In this way, we are able to deliver a multidimensional session of treatment at the same time. And we decided to adopt this type of technology, not just only because we love innovation or technology, but because even the literature and the scientific literature actually is supporting the use of virtual reality in the field of rehabilitation. And let's talk about the stroke paradigm. Just only talking about virtual reality and stroke, that it's only a part of the field, of the larger field of rehabilitation, we can see that actually in PubMed we'll be able to find more than 600 papers published about virtual reality and stroke, and that the interest in these type of issues and topics is increasing during recent years, and there is a stable increasing trend in this sector. So technology is offering a very concrete possibility of rehabilitation intervention in the clinical practice. Even the Cochrane Library delivered a Cochrane review about virtual reality for stroke rehabilitation. And in this review, the authors have been able to include 72 trials that involved almost 2,500 participants. And new studies are going on and going on by the time. What were the authors' conclusions in this type of review? They concluded that the use of virtual reality, or any sort of interactive exercise during the rehabilitation process can be introduced in the conventional therapy, and the virtual reality rehabilitation may be beneficial in improving upper limb function and activities of daily life function. Actually, there are insufficient evidence to reach conclusions about the effect of virtual reality on gait speed, balance, participation, or quality of life. But clearly, it depends about the type of patients, the type of rehabilitation targets that the clinician has in his mind, and the results that you can obtain. Probably there's a trend suggesting that a higher dose of exercise in the virtual reality setting, more than 15 hours, is able and is preferable to be delivered to the patient than a lower dose one. And here you can see some reference table, and I will delivering the PDF version of the slides, and so you'll be able to see the results on this table. I don't want to annoy you with these results. Some other experiences based upon the use of virtual reality rehabilitation for cognitive rehabilitation provided some more results during recent years, just only 2 years ago, in the field of stroke rehabilitation. In this study, our colleagues recruited an experimental group and a control group, and they delivered a virtual reality rehabilitation session. As you can see here, the patients experienced good results in terms of cognitive improvement as well in the control group. But probably, according to some point of view of the cognitive assessment, the experimental group received more beneficials than the control one. So, in this case, the virtual reality setting can be used to deliver even cognitive rehabilitation, probably, especially for stroke patients, but not only. So, what is our actual project on the NIRVANA system here at the Domus Salutis Clinic? Actually, we began our experience with a proposal for a retrospective observational study protocol, and we are testing this protocol. I want to show you the preliminary results coming from this experience. The aims are to demonstrate the validity of the virtual reality NIRVANA system according to different parameters: usability, effectiveness, patient tolerance, and to define the minimal criteria for the inclusion of the patient in the treatment protocol, even to create an assessment format as a common tool eventually for multi-center studies, or to define standard technical protocols according to the specific and individualized assessment of our patient, because our patients during the acute phase of rehabilitation are actually changing every day. They are not a stable model of intervention and treatment. They are changing their cognitive and motor profile day after day clearly. In this assessment format for the NIRVANA system evaluation, I introduced some demographic data, some data about the type of medical diagnosis we are talking about according to the ICDH model: stroke, multiple sclerosis, type TBI, Parkinson's disease, spinal cord injured patients, and so on. Their last known mini mental test examination value. And then some other data about their ability to move inside the hospital, independent without assistance, or wheelchair bounded needing assistance for mobility. The main target for the treatment, because of any clinician can decide eventually to use the virtual reality system to deliver the treatment for the upper limb, dynamic or static balance, the balance of the trunk while we are sitting, or the cognitive performance, and eventually the type of treatment modality: total independent, with physical assistance, with verbal assistance, or only with surveillance. And what else I introduced in this format? I introduced the use of 4AT Delirium assessment tool, and this is a very interesting tool because this can be used for a rapid and quick screening of the cognitive profile that of the patient that we have in front of us. As you can see here, the score can go from 0 to 11, and clearly 0 is a normal patient, and 11 is very, very severe compromised patient. The 4AT Delirium assessment tool is consisting to give a score in the level of alertness and in the ability of the patient to recognize age, date of birth, name of the hospital, and the current year from 0 to 2, and the attention level, thanks to the ability to answer to the name of the month and year, beginning from the end of the year, from December, and going to January. Or eventually, we can give from 0 to 4, whether the patient is presenting an acute change or a fluctuating course from day to day. In this case, we can in a very fast way assess the cognitive profile of the patient. Then I decided to propose the use of the functional ambulation classification, just to categorize the ability of the patient to move inside the hospital from 0 to 5, from non-functional ambulation to ambulator independent patient. And this is a way to understand what type of patient we are introducing in the setting of the virtual rehabilitation session that day, at that time of the day. Then actually we are scoring the motor performance of the patient on the upper limb thanks and through the use of the motricity index scoring system from 0 to 100 and exploring the ability to perform the pinch grip, the elbow flexion, or the shoulder abduction. And then we are assessing the ability of the patient to control the trunk thanks to the use of the trunk control test from 0 to 100 once again. During and immediately after the end of the rehabilitation session, we are asking to the patient, eventually they had some distressing experience according to pain, eventually if he had any pain in any district of their body during the session, or the amount of fatigue according to the rate of perceived exertion according to the Borg scale from 0 to 10. One of the targets, if you remind, was represented by the possibility to evaluate the usability of the system. And for these purposes, actually, for this purpose, we are using the system usability scale. And this is a very well validated scale that has to be used when you are introducing a new device in your clinical setting. The system usability scale is consisting in 10 different questions, and the range goes from 0 to 100. 72 point is the cutoff level to define the usability. If the system is above 72 points, the system can be used in a very easy way. If the score is below 72 points, clearly you have to pay attention because there are some critical points that has to be considered. So what are the results? First of all, 86% of our patients, of our sessions were performed with patients presenting a 480 score below 4 points. 55% were classified according to the functional ambulation classification from 2 to 3. And the RPA Borg in 77% of the case was below 4 on 10. And the usability was pretty high because 60% overall of the patients were presenting a score above 72, while only 40% of the session were performed below 70 points. The mobility, most of the times, the patient were leaving the rehabilitation session with the virtual reality system during an independent gait, but under supervision or eventually using a walker, while 36% of them were completely independent without assistance during the treatment. The upper limb was the main reason for introducing the patient in the virtual reality. So the occupational therapist, the physiotherapist, they asked to introduce the patient in the NIRVANA treatment, just having in their mind the upper limb as a rehabilitation target. And what are the results? We decided, and I asked to the clinicians to collect this type of data from the assessment format during the first, the second, and the third one of the rehabilitation sessions. And so we collected the first 3 sessions of treatment from 1 to 3. The functional ambulation classification score increased from the on average, increased from the first to the third one. The trunk control test value was stable. The motricity index pinch score was pretty stable with negligible negative change. The motricity index subscore in terms of elbow flexion was stable, while the motricity index subscore in terms of shoulder abduction improved even during the third session, because probably of the specificity of the type of exercise we proposed to the patient. The Borg on average scored 3 on 10 since the beginning of the sessions, and after 2 sessions of treatment, the average score went down to 2.5 points. The cognitive assessment according to 4AT scoring system maintained an average value below than 4 on 11, and we introduced and we performed all the sessions with an average score of 1.5. Anyway, with a pretty high standard deviation, because the range of the value according to the 4AT went to 0 to 8. The system usability scale, since the beginning of the treatment, presented a very positive way of value of usability, because on average, since the beginning of the session, on average, the patients reported a score of 78, and the usability of the system maintained a good stability overall during the other sessions of treatment. I tried to use all the data derived by all the 3 sessions of treatment in the aim to understand the eventual existence of some correlation among all the different parameters we collected. And what I recently discovered is that the value of 4AT score is in some way related to the score of the system usability scale. It means that the higher the value is of the 4AT, the lower is the usability, and this is probably acceptable, because clearly the more the cognitive impairment is relevant, the lower is ability to attend in complex tasks for the patient. And the correlation coefficient is negative, and is 0.66 with a p-value of 0.0013, a very, very high correlation of the 4AT value with the usability of the system. And in this way, probably, we can understand, we can argue that we can use the 4AT scoring system to assess the cognitive ability of the patient in a few minutes before introducing the patient in the virtual rehabilitation session, because today the patient can show a certain ability in terms of cognitive performance, while tomorrow this cognitive performance, for several reasons, cannot be the same. And we need to provide a very rapid screening of this phenomenon. The 480 value below than 4 on 11 allow the clinician to introduce the patient in a very, very positive way to the virtual rehabilitation session, while a score from 4 to 6 probably is going to generate a yellow area. And you have to, as a clinician, we have to pay attention in the way we are delivering the treatment, because eventually can be too complex for the patient. And more than this, if the patient is presenting a 480 value above 6, we have to pay attention, because probably we have to provide a minimal intervention in terms of virtual rehabilitation, because otherwise some criticism will be arising from the session. Thanks to the use of the 480 and all the other parameters, probably we are now able to decide in a very quick way, in less than 5 minutes, whether that day we have to introduce the patient in an easy algorithm. I mean, we can ask the patient to provide to do the exercise of the bridge, to follow the footprints, to escape from the dog, but certainly will be not delivering an exercise to stress the cognitive impairment, because that day the patient probably wouldn't be able to attend to this type of exercise. While in the case the 480, that day would be below than 4, probably will be able to use the hard algorithm and will be able to do some more stressing exercises with our patient, air hockey, arcanoid, balloons, but also cooking or memory exercises, alphabet, counting, and all together will be able to switch from a motor exercise to a cognitive one, or will be able to exploit in a dual task environment the motor and the cognitive exercise at the same time for our patient. And I want to thank all the people here of the rehabilitation groups, because they work to deliver us and to give me these results. I hope that this preliminary experience is now able to help us in better understanding how to deliver the virtual rehabilitation session with our patients. Otherwise, we have the risk not to treat in a proper manner our patient in a specific time during the multidisciplinary rehabilitation program. Thanks to all for your attention. I'm ready to answer to your questions.
Very well. Thank you very much, Dr. Bissolotti, for your presentation, because you shared with us your great experience and also a very interesting methodology that I hope also the other center can exploit. And just a few seconds, because I would like to remind you the next appointment. So I'm waiting for all of you in the next appointment scheduled on the 5th of December with the theme of Neurology Institute of Messina. And they will explain us how they are using the NIRVANA system in the treatment of children with autism spectrum disorder. And I also remind you that if you had joined at least 3 of these 4 webinar of this NIRVANA webinar series, you will get also a certificate of participation that we will send. So thank you very much to all of you for your attention and for your time, and thank you again, Dr. Bissolotti, for your great presentation. So see you on the next webinar.